The Clinical Swallow Eval, the CSE, is a big part of what we do as medical SLPs. The CSE allows us to develop a relationship with the patient, per Coyle 2014, and a hypothesis about the patient's swallow function. The CSE guides our dysphagia plan of care, including what type of instrumental testing will be beneficial if needed. At the close of the clinical swallowing examination, the clinician should be able to confidently develop a management program for the patient or determine the necessity of further instrumental assessment or subspecialty referral. That's Murray 1999. But our job doesn't stop when we finish the CSE. We need to document it appropriately so that other members of the medical team understand our clinical decision-making. And remember, if it wasn't documented, it wasn't done. Today we'll be talking all about how to write a swallow evaluation report and what to include in your documentation for a CSE. Let's dive in.
I'm Teresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education.
Number 1, SOAP notes. SOAP notes are widely used by healthcare professionals. Pulling directly from the 2021 paper by Potter and colleagues titled SOAP Notes, here's the basic outline of a SOAP note. Subjective. This is the first heading of the SOAP note. Documentation under this heading comes from the subjective experiences, personal views, or feelings of a patient or someone close to them. In the inpatient setting, interim information is included here. This section provides context for the assessment and plan. This is where you might write something like, patient reports being in a good mood and is eager to start therapy, for example. Objective. This section documents the objective data collected during the patient visit. Here is where you share scores, measurements, and other measurable information. Assessment. Your assessment is the synthesis of the subjective and objective sections to arrive at a diagnosis. Basically, what do you suspect is going on and why? The plan. This section details any additional steps being taken to treat the patient, the need for additional testing, and any need for consultation with other clinicians to address the patient's problem. Do you plan on providing therapy? Are there other assessments that should be considered? Don't worry, we'll be discussing each section in detail in this video for how to write your CSE. First, let's talk about the difference good documentation can make. Here's an example many of us have heard or experienced at some point in our MedSLP career. An SLP completed a new clinical swallow evaluation, consult, and documented gradually worsening dysphagia, dysarthria, and lingual fasciculations. The SLP recommended a neurology consult due to concerns about the patient's symptoms. The SLP reached out to the medical team, but the doctors were busy and unable to return the page until later that night after the SLP had already left for the day. Without the ability to directly communicate with each other, the doctors read the SLP note and recommendations. A neurology consult was placed due to the SLP's great documentation. Because of this, the patient was able to receive an accurate diagnosis from neuro of ALS and begin appropriate treatment. It's important to remember that we need to document everything we see, especially if it raises any concerns. One phrase I always heard as a clinician was, if you didn't document it, it didn't happen. Number 2, deep dive into each section of the SOAP. Okay, let's take a bit of a deeper dive into each section of the documentation, starting with the subjective section. Include your impressions of the patient. Are they awake, alert, cooperative, and fully oriented? Or are they lying in bed, oriented to self only, and with labored breathing on 10 liters of oxygen through the nasal cannula? Paint the picture for anyone reading your documentation of what condition the patient was in when you arrived to evaluate them. Include the patient's chief complaint. Per Potter and colleagues, this could be a symptom, condition, previous diagnosis, or another short statement about why the patient is presenting today. Some examples include coughing with PO, difficulty swallowing bread, or I want to drink regular liquids. Your patient can have multiple chief complaints. For example, coughing with PO, and my voice is different since surgery. This is important information that helps to paint the entire picture. You can also include history of present illness, referred to as HPI here. Some documentation systems have a different section for this, so also follow the guidelines for your employer. As Potter and colleagues outline in their article, include as much of the following as you can in your HPI. Onset. When did the chief complaint begin? For example, this has been getting gradually worse as I've gotten older, versus this happened suddenly after my stroke. The location. Where is the chief complaint located? For example, I feel food stick in my chest, or I don't feel any food sticking, but I do cough like things went down the wrong pipe when I drink. The duration. How long has the chief complaint been going on for? For example, this has been happening since my stroke 2 years ago, or this just started last night after my surgery. Characterization. How does the patient describe the chief complaint? Coughing, sticking, or something else entirely? Alleviating and aggravating factors. What makes the chief complaint better or worse? Small sips seems to help, or softer foods make it easier for me to swallow. Radiation. No, not the electromagnetic waves radiologists use. Radiation here refers to the movement of the sensation, as in, does it radiate? Does the chief complaint move or stay in one location? For example, it sticks in my chest and then never seems to come back up. Temporal factor. Is the chief complaint worse or better at a certain time of the day? For example, swallowing is easier at the beginning of the day or the start of a meal. This would be a big red flag for myasthenia gravis. Severity. Using a scale of 1 to 10, 1 being the least, 10 being the worst, how does the patient rate the chief complaint? This doesn't really bother me. I just have to cut my food into smaller pieces. Versus, I am so embarrassed that I can't eat my favorite steak at dinner anymore without it falling out of the side of my mouth. Include pertinent information about medical history, medications, lab results, surgical history, family history, and social history. One member of the MedSLP Collective shared a win about the quality of her documentation being recognized by others. She shared that she assumed other disciplines didn't really read her notes, which I think a lot of SLPs can relate to. However, after she completed an evaluation on a patient in the ICU, she noticed that the neurohospitalist copied and pasted the detailed history she wrote for his H&P. This was a nice nod of recognition in 2 ways. First, she was happy to see that her notes sufficed his standards, as their neurohospitalists write very thorough notes. Second, it showed her that the neurohospitalist actually looked at her notes and appreciated what SLPs had to contribute. It may feel like a small win for some, but for her this felt like a wonderful sign of progress, especially since she had been working on promoting a high standard of writing for clinical documentation throughout her entire department. Another collective member also shared a win about her documentation, and this one involved a direct compliment by a physician. She shared that documentation is one way she tries to illustrate her knowledge, so she's very thorough with her reasoning, resources, and rationale behind her decision-making. One day, a physician sent her an email that said this: I love reading your notes because I always learn something new from them. I can't remember what I learned last week, but I remember pausing to think about how impressed I've been with you. You're incredibly talented. Our patients and team are so fortunate to have your skill set, your compassion, and your dedication. Okay, if that doesn't motivate you to improve your documentation, I am not sure what will. I will be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Do you have any specific questions about writing a swallow evaluation report? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. Make sure to stick around to the end to claim a freebie or 2. Number 3, continuing the deep dive. Now let's move on to the objective section. Remember, this is the section where you document the objective data from your patient encounter. This includes vital signs like respiratory rate, oxygen saturation, heart rate, and blood pressure if that measurement is available. Your exam of the oral cavity and the oral mech exam, cranial nerve exam, assessment of airway protection or the presence and strength of the cough, cognitive screen like the slums for example, 3-ounce water challenge, any other PO trials, predictors of aspiration pneumonia as outlined by Langmore. Next is the assessment section. Remember, as Potter and his colleagues outlined in their paper, this section documents the synthesis of subjective and objective evidence to arrive at a diagnosis. This is the assessment of the patient's status through analysis of the problem, possible interaction of the problems, and changes in the status of the problems. In a nutshell, this is where you list the problem or problems and your differential diagnosis. Here are some example phrases you might see in the assessment section of a clinical note. Example 1. Low concern for oropharyngeal dysphagia based on the patient's symptoms and clinical history. However, given this patient's complaints of esophageal symptoms like sticking in the sternal region with solids, and history of unintentional weight loss, a referral to GI is indicated. Example 2. Patient presents with signs and symptoms of oropharyngeal dysphagia in the setting of an acute right MCA CVA. VFSS is recommended to objectively evaluate swallow function. You can also discuss individual risk factors for aspiration pneumonia or other dysphagia-related complications in this section of your note. Okay, now we finally move on to the plan section. This is where you share your plan. Does the patient need additional testing? Do they need an ongoing SLP assessment or therapy? Remember, you can't really plan much therapy without a VFSS or fees if possible. Examples of things you may recommend in your plan: VFSS or fees, a diet or NPO with alternate means of nutrition, hydration, and/or medication, no further SLP therapy, SLP therapy, which will likely be based off your VFSS or fees, or an outside hospital's VFSS or fees, specialist referrals or consults such as GI, neuro, ENT, rheumatology, patient education or caregiver counseling. Other reasons to be thorough with your dysphagia assessment documentation is to cover yourself, document proof of observations, and demonstrate evidence-based rationale for your clinical decisions. All of this can be particularly helpful in the case of litigation. Although rare, SLPs and other healthcare professionals can be litigated in cases of harmful outcomes. Even if you aren't the SLP involved in the lawsuit, you could be asked to use your knowledge and skills as an expert witness. For example, one SLP was asked to work with a lawyer to provide an expert SLP opinion on a lawsuit case. A patient had choked during a meal at the hospital and died as a result. The facility the patient was in had kept medical records from the time the patient had been there. The SLP was asked to go through the hospital's documentation, including SLP and nursing notes, to help determine if the facility was at fault in this patient's death or not. The patient had been documented as needing one-on-one assistance and a modified diet. I don't know the outcome in this particular case, but I do know that this is an important example of why your documentation matters. If this assistance was provided at the time of death, or if it wasn't, that could greatly affect the outcome of this lawsuit. Your documentation can protect you in cases of a lawsuit. And outside of legal matters, clear documentation helps get your evaluation and recommendations across to the medical team. Want to keep learning about clinical documentation as an SLP? I have 3 treats for you. Head on over to medslpcollective.com and download the clipboard kit if you haven't already. We have a clinical swallow exam resource from the collective on page 16, and it is yours for free. Next, check out episode 176 of the Swallow Your Pride podcast, where I interview Kelsey Day about this very topic. The episode is titled How to Become Confident and Competent in Clinical Writing. Next, if you are already a MedSLP Collective member, we have an entire webinar dedicated to clinical writing, titled Documenting and Report Writing for Dysphagia Instrumental Assessments. If you're not a member of the MedSLP Collective, check out this special link in the description to go ahead and join and gobble up this webinar.